Okay, and next one, you had a 70-year-old female who came in with sudden onset of severe left periorbital pain. She has reduced visual acuity on examination. She has, why not lipoma? In this case, it was brown, and usually lipomas, they'd be, skin colored, and they'd be raised, and they'd be easy to move around as well, with regards to their, when you come to examine them, they'd be a raised lesion, it would be skin colored, it wouldn't be a different color. Lipomas usually are the same color. And then when you biopsy them, it would show, the fatty tissue, whereas in this case, it showed basal layer proliferation. Perfect. Okay. The next one, you had a 70-year-old female who came in with sudden onset of severe left periorbital pain. She has reduced visual acuity on examination, conjunctival injection, and the pupil is mid-dilated and non-reactive. Which one of the following is a most likely diagnosis? So it was sudden, it's left periorbital pain. She also has reduced visual acuity, conjunctival injection, so it's red. The pupil is mid-dilated and it's non-reactive. So that very much sounds like acute angle closure glaucoma, especially because of how sudden it was, sudden onset, reduced acuity, and the redness of the eye and everything. So it's an emergency. It's caused by blockage of the canal of Schlemm, which prevents the fluid from being drained from the anterior chamber. Usually patients are, elderly females, because they already have shallow.
It's 2 o'clock.
Because they already have shallow anterior chambers, and sometimes they have hypermetropia, which increases their risk. And sometimes they have no history of glaucoma. But yes, they usually present with periorbital pain. Sometimes they also have nausea, vomiting, and visual deficits. And pain is associated with a headache on the same side. Sometimes they can have blurry vision. They can start to see halos around objects, and pupil dilation can make the problem even worse. So that's why the attacks are commoner at night, but the attacks can also happen, when you're watching something on TV in the cinema, or if you're at a place where there's a lot of lights that are being flickered on and off. So careful investigation may elucidate a precipitating factor, whether it was a dim light, an anticholinergic, or a medication that might have caused the pupils to dilate and have this acute angle closure. On examination, they usually have reduced visual acuity, and testing reveals the ability only to detect hand movements, and you can see corneal and scleral injection, so redness around, and ciliary flush as well. There's also edematous and cloudy cornea obscures a fundoscopic examination, so you can't usually do fundoscopy because everything is cloudy and edematous, and they usually have an increased intraocular pressure over 20 millimeters, and ischemia can result in the pain on eye movement. A mid-dilated, non-reactive or fixed pupil, and a firm globe, which in this case she had the mid-dilated, non-reactive pupil. Treatment for acute angular closure glaucoma, so you want to give them acetazolamide to get rid of all the built-up of aqueous fluid in the eye to reduce the intraocular pressure, and you can also give them pilocarpine to help constrict the pupil, so they're not as dilated and more prone to having this angle closure. And then once it's controlled, they can either be referred for surgical or laser iridectomy, so it doesn't happen in the future. Okay, the next one, you have a 40-year-old male who's struck in the right eye with a squash ball. His visual acuity is unaffected, but he complains of diplopia. On examination, his right eye looks sunken in, and he's unable to look downwards with the affected eye. There's also numbness of his right cheek and upper gum. Which one of the following is the most likely diagnosis? So he was hit by a squash ball, and now his visual acuity is not affected, but he's having diplopia. And his right eye looks like it's sunken in, and he's unable to look downwards. There's numbness in his right cheek and right gum, so that just looks like he's fractured his eye, so orbital, like around his eye, so his orbital bones, orbital blowout fracture. If it was a ruptured globe, he would have been blind and in a lot more pain, and it just doesn't fit with anything else. So orbital blowout fracture may result when a blunt object, which is of equal or greater diameter than the orbital aperture, like a squash ball, strikes the eye. The globe doesn't rupture, and the resultant force is transmitted through the orbit, and so the the fracture ends up hitting the orbital floor. Signs and symptoms, they can either be asymptomatic with just a little bit of bruising and swelling. They can have diplopia, they can have enophthalmos where there's tearing as well, hypoophthalmia or hyperglobus or hypoesthesia, so they can lose sensation of the cheek and upper gum of the affected side. A bulging eye. So 43, you had a 60-year-old male who complained of sudden loss of vision, like a curtain falling down, preceded by flashing lights and floaters. On examination, he has reduced visual fields. Which one of the following is the most likely diagnosis? So this amaurosis fugax, or what they say when the curtains are falling down, that usually happens when there's retinal detachment. So retinal detachment, when there's separation of the inner neurosensory retina and the outer retinal pigment epithelium, the space between them becomes, filled with retinal fluid, and you get this curtain falling down. So it feels like there's curtains shutting down in their eyes. So it can be RD, rhegmatogenous retinal detachment, or non-rhegmatogenous, and it depends on the cause. So it could be tractional, the vitreous because of diabetic retinopathy, or it could be exudative because of severe hypertension, or something of that sort. Most commonly, the age is between 40 to 70, and the risk factors, if they've had it in the past, or if they had a posterior vitreous detachment, if they have high myopia, if they have a family history of retinal detachment, if they've had previous eye surgery, if they've had trauma. Either ways, they come in with the 4 Fs. So the floaters, the flashes, the field loss, and the fall in acuity. So the floaters, the flashes, it's also known as photophysia in 50%, field loss and fall in acuity, painless and often described as a curtain falling over the vision. So that's like amaurosis fugax. And when you do ophthalmoscopy, you'll see the gray retina ballooning forward, because it's detached from his side. So for them, you need to refer them urgently for surgery. Next one, you had a 27-year-old female with multiple sclerosis presenting with deteriorating visual acuity and impaired color vision in her left eye. On fundoscopy, the optic disc is noted to be pale. Which of the following is likely diagnosis? Patients with multiple sclerosis are at risk of getting optic atrophy, and that could impair their color vision as well as their visual acuity. So that would be optic atrophy. So it's a term for loss of a proportion of the optic disc nerve fibers. It's an important sign of advanced optic nerve disease. It's said to be primary if it occurs without any preceding event, so like an optic nerve head edema, or secondary if it's preceded by edema. So if there's edema first, then it's primary. If not, then it's secondary, and it may lead to maybe due to retinal lesions, so like an occlusion of the retinal artery or vein because of tobacco, nutritional, optic nerve lesions, so chronic glaucoma can be a cause of that. Pressure on optic nerves, so by tumor, by glioma, by meningioma, by Panget's disease, chiasmal compression, so a pituitary tumor, a craniopharyngioma, or a suprasellar meningioma, or a stroke, or optic tract lesions like pituitary adenoma. And then the presentation is different, but with optic disc atrophy and oscillation, it could result in loss of vision, can be central or peripheral, and they may have a degree of color vision impairment, especially if it's that type of optic atrophy where they can have blue-yellow disc chromatopsia, so they have difficulties with seeing blue and yellow. And then when you do a fundoscopy, you'll see a pale optic disc like we saw in this patient, and there's usually a reduction in the number of the small blood vessels crossing the surface. Okay, the next one was a 35-year-old metal grinder. A 35-year-old metal grinder was not wearing protection goggles when grinding some metal. He presented to A&E with a corneal abrasion. Which one of the following types of stain would you instill onto the surface of the cornea to help you detect corneal abrasions? This one's straightforward. It's in every A&E. You'll find fluorescein, which you can use to see if there's any abrasions in the eye or not. So that's okay. Next one, you have a 20-year-old female who complains of a 2-day history of left ear pain following a history of self-cleaning of the external auditory canal. On examination, there is vesicles on the tympanic membrane. Which of the following is the most likely diagnosis? So 2 days history of left ear pain following self-cleaning of the external auditory canal. There's vesicles on the tympanic membrane. What's what's a most likely diagnosis? So because it's on the tympanic membrane, that rule out, otitis externa and acute otitis media, because you wouldn't have seen, vesicles on the membrane if it was otitis media. Ramsay-Hunt syndrome, you have vesicles on the external auditory canal, and also you'd have, features of like Bell's palsy, which she didn't have. Barotrauma, usually they'd have a history of flying or being in a pressurized sort of room. So this would leave us with the last one, which is bullous meningitis. So in that case, you have painful vesicles, and usually they're found on the tympanic membrane. And usually it can happen with mycoplasma or viral respiratory tract infections. And it can be superimposed with a bacterial infection, or it can come on top of a bacterial infection with like otitis media. And treatment, you give them antibiotics, analgesics, and drain the vessels if needed. Okay, the next one, you had a 41-year-old female who presents with severe vertigo accompanied by nausea and vomiting, tinnitus, and loss of hearing in the left ear. She's recovering from a recent viral respiratory tract infection. On examination, she has nystagmus towards the right side. What's the likely diagnosis? So for this case, because she has, tinnitus as well as hearing loss, so vertigo as well as hearing loss, it means, both the vestibular and the cochlear part of the vestibulocochlear nerve are involved. So because it's viral, it's either vestibular neuritis or labyrinthitis, right? Those are our differentials. If she didn't have the vertigo, or if she didn't have the hearing loss, then it would have been vestibular, because then it just affects, the balance. But because she's having hearing loss as well, it points more towards labyrinthitis. So labyrinthitis, inflammatory disorder of the inner ear. Usually you have an upper respiratory tract infection. It can cause vertigo with sweating, nausea, vomiting, diarrhea, tinnitus, and sensory neural deafness as well. You also get nystagmus towards the opposite side of the lesion. In this case, it was right, but it was her left ear. And the symptoms of an acute vestibular episode can be treated with, an antiemetic or prochlorperazine, promethazine, or cyclizine. And then vestibular sedatives, you can give them a calcium channel antagonist like cinnarizine, or the one that's used more often is the histamine analog, so beta-histine as well. And usually it just self-resolves on its own, and they get better. If not, you can give them these just to support with symptomatic treatment. Okay, next one was a 19-year-old male student who complained of increasing deafness in his left ear. You examine his ear and you find out that his auditory canal is impacted with hard wax. Which of the following symptoms would not be compatible with diagnosis of earwax? So discomfort, conductive hearing loss, dizziness maybe, and tinnitus maybe as well. But ear painful when moved doesn't make sense because there's just wax. So when you move it, it shouldn't really be painful. That indicates that there's some sort of infection brewing as well. So wax, sermon oris on the outer third of the auditory canal to protect against maceration. So they can either be asymptomatic, have conductive hearing loss, blocked ears, discomfort, tinnitus, itchiness, and vertigo. These are all fine. Usually they can get, water in the ear from swimming, showering, that can cause the wax to swell and block the canal. The commonest cause of unilateral deafness in, children and young adults. And softening the earwax with olive oil or with some serminolytic agent, an agent that breaks down earwax, can help the wax come out. And if it's not sufficient, then usually GPs can they can go to the GPs and have them removed with warm water, or a curette method by ENT surgeons. The next one was a 10-year-old boy who presented with pain in both his ears. He flew back from India yesterday, and his mum reports that he had a difficult time on the flight and even had a nosebleed. On examination, there appears to be an extensive middle ear hemorrhage with blood bubbles visible behind the tympanic membrane. Which one of the following is the most likely diagnosis? So because he was on a plane and it ruptured and he's having the bleeding and the bubbles and all of that, it very much sounds like barotrauma. And the fact that his age is 10, that doesn't fit with nasopharyngeal. Bullous meningitis, we saw another presentation. This isn't how they present with. ITP doesn't make sense, and acute otitis media would be more of an infection sort of presentation rather than, went on a flight and now there's blood and hemorrhage and blood bubbles visible in his tympanic membrane. So it's fitting with barotrauma. It's often due to descent in aircraft and can be seen in divers as well. It's painful with sensation of pressure on either one or both ears. You can hear ear popping, hearing loss, and ear discomfort. Sometimes they can have epistaxis as well, and sometimes you find the fluid behind the eardrum. or hemorrhage, and they can have conductive deafness. Usually it clears spontaneously. It takes several weeks, but you can give them antibiotics to prevent infection if it's very severe. Okay. The next one was a 16-year-old male who presented with nosebleeds every day for the last 2 weeks, fortnight. On examination, he has multiple dilated capillaries on his lips, oral cavity, and fingers. His father, who since passed away, had similar problems. Which one of the following is the most likely diagnosis? So dilated capillaries and runs in the family. It's 𝕊𝕆ᴛ𴀶 syndrome. So 𝕊𝕆ᴛ𴀶, hereditary hemorrhagic telangiectasia, autosomal dominant. You have the triad, telangiectasia, recurrent epistaxis, and a positive family history. So he had sort of all of those: telangiectasia, positive family history, and nosebleeds, so the recurrent epistaxis. Okay, so the major cause of morbidity and mortality is if there's multi-organ involvement, multi-organ atriovenous malformations, and they can have hemorrhage. The incidence is not that high, and symptoms vary depending on the area of involvement, but usually it's within the nasal mucosa, the skin, the GI tract, the pulmonary vasculature, and the brain. And they can also get telangiectasia on their lips, like in this case. The most common presenting symptom is nosebleeds, so epistaxis, and that's in 90% of patients. And they can have it as often as every day or as infrequently as once a month. And usually they present before they're 20 years old, so when they're quite young. And sometimes they need blood transfusions or surgical treatment. Okay, the next one was a 71-year-old patient who was diagnosed with prostate cancer 2 years ago. He had radiotherapy and his prostate-specific antigen had been normal and stable for the last year, but in the last few months, the PSA level is starting to rise. He's well informed and asks if he should be on hormone treatment. In which of the following situations would hormone treatment be started? So usually they start it if it's doubling in less than 3 months. So that would be the answer. So if it's doubling less than 3 months, or if they're symptomatic, or if there's proven mets, then you'd want to start them on hormone treatment. So that would be your 3 things to look out for. If there's symptomatic local disease progression, or if they have mets, or if their PSA is doubling within 3 months, then they'd be candidates for hormone treatment. A 13-year-old boy is admitted to the hospital complaining of sudden onset of severe central abdominal pain and pain in the scrotum. He's been previously well apart from a recent upper respiratory tract infection. On examination, the left side of his scrotum appears to be normal, but the right side is swollen and very tender. And the right testis appears to be lying high in the scrotum. Which of the following is the most likely diagnosis? So high riding, transverse, those all point towards torsion of the testes, but it's also the fact that he's 13 and it's sudden onset and it's abdominal pain that points towards towards testes as well. So it's a surgical emergency. It's because of interference of the blood supply to the testes and associated with imperfectly descended testes. So that's why usually they're younger. It's horizontal lying or transverse lying, high riding. Those are all the descriptive things of a twisted or a torus testes. And then clinically, the patient presents with acute onset of pain, just like in this case, and it can go from anywhere from the scrotum to the groin, radiating to the lower abdomen, associated with vomiting. The testes itself is tender, it's drawn up in the scrotum. It's difficult to distinguish between the torsion of the testes and epididymoorchitis or orchitis. But in this case, though, he didn't have any signs of infection, the temperatures or the fevers, none of that. So that pointed more towards torsion. And however, in an inflammatory condition, there will be signs of infection. Again, yes, so increased white cell count, temperature, a dipstick that's positive. And in addition to this, the testes isn't usually high lying, and it's not high riding or transverse in epididymoorchitis. So that's how to differentiate between both. Okay, the next one was a 27-year-old married lady who returned from her honeymoon in West Africa with a 2-day history of nausea, loin pain, and painful micturition. On examination, she's flushed, mildly tender in the right loin with maximal tenderness in the suprapubic region. Which of the following is most likely diagnosis? So she just returned back from her honeymoon with 2-day history of nausea, loin pain, and painful micturition. On examination, she's flushed, she's tender in her right loin, maximal tenderness in the suprapubic region. So that sounds like a UTI. People who go on holidays on their honeymoon, they can develop UTI. So because it's a risk with the increased sexual activity on holiday, so they usually get honeymoon cystitis, and if a urine dip would come back positive, and then the patient can be started on antibiotics. And also she had like suprapubic tenderness, and loin tenderness that didn't radiate or anything, so it fits with UTIs. Why not ectopic? The dysuria, the dysuria, the nausea, and the fact that, for me, it was the dysuria and the nausea and loin pain, and it was only for 2 days. That's what made it more towards UTI than ectopic pregnancy. They also would have mentioned something about, last menstrual period, if it was ectopic pregnancy, to be pointing more towards ectopic pregnancy, last menstrual period, or they would have, last menstrual period would have been mentioned. Because they're both common after a honeymoon, so you could either get ectopic pregnancy or you could get UTI as well. They're both high risk after going on honeymoon. You could get honeymoon cystitis, or you could get pregnant. But in this case, the loin pain and the painful micturition, specifically the painful micturition, that pointed more towards UTI than ectopic pregnancy. And other things you would have seen with ectopic pregnancy might have been like, right shoulder pain or the left shoulder pain, depending on where it was, obviously, but they would have made it more obvious. And in real life, you would have done both the beta-HCG or the, pregnancy test, as well as the urine dip for UTI. Okay, next one was a 79-year-old man who came into A&E having not passed urine for 18 hours. He's complaining of severe lower abdominal pain. He gives a history of hesitancy, poor stream, dribbling, together with nocturia. On examination, he has a large smooth mass arising from the pelvis, and rectal examination revealed a large smooth anterior mass. Which of the following is the most appropriate next step in management? So the first thing you want to do is deal with his urinary retention. So that would be to put in a catheter. You can put in a super... you can put in just a normal catheter because there's no sign of bleeding or anything of that sort. So you can put in a normal catheter for him, and then deal with the fact that, he's got a prostate, a smooth BPH, that he's got benign prostatic hyperplasia. Okay, so the next one, you have a 51-year-old woman who presents to A&E with severe colicky pain radiating from her right loin to her groin. An analysis of her urine reveals blood, no leukocytes, no nitrates, and beta-HCG is negative. Which of the following is the most likely diagnosis? So the minute you see blood, the minute you should think of stones, and the fact that it's radiating from her right loin to her groin makes it more likely to be a renal stone than a bladder stone or something else. So renal calculi, you have loin to groin pain and painless hematuria, but you check for beta-HCG if they're premenopausal, just like in that woman. And then CTKUB would be the next investigation to help confirm the diagnosis, but you need to give her, IV fluids and analgesia. Why not blockers? Because it asked for the. I'm assuming you were talking about the previous one, or are you talking about this one? Are you talking about this question? Because it is BPH, but they asked about the most appropriate next step in management. And the first step you'd want to do is relieve this urinary retention, because he's been having urinary retention secondary to his BPH for the last 18 hours. And that could be really bad because his bladder might rupture or anything of that sort. So you'd want to deal with that first and then give him the alpha blockers or whatever it is for his BPH.